Hi everybody, this is Dr. Eric Dinkins, physical therapist, and today we have a topic of discussing orthostatic tremor. We have Becky here. Becky and I have been working together on our orthostatic tremor for the last several years, and we've made some very nice progress, so we wanted to just kind of discuss your progress a little bit and bring some awareness out into the communities about some differences around orthostatic tremor, specifically primary orthostatic tremor, and how it might present in your clinic, maybe some treatment options for you, and then of course how it's affected Becky's life. So to start with, orthostatic tremor is commonly underdiagnosed in the community. It's defined by a much higher frequency tremor than essential tremor, much higher frequency than Parkinson's disease. Both of those are around somewhere between 3 and 7 hertz, which is going to be how many beats per second. Really, if you want to think of it that way. And everybody understands, especially with Parkinson's, kind of the generalized look of that or the presentation. Essential tremor is a tiny bit different. It doesn't follow certain characteristics of Parkinson's does, but the frequency of essential tremor is very, very similar. If we compare that to orthostatic tremor, it's much higher, so it's somewhere between 11 and 17 hertz, so it's double to triple that of essential or Parkinson's disease types of tremor. And it primarily presents in standing or weight bearing. And so this is very disruptive for people who are dealing with this progressive neurological condition because it gets in the way of societal interaction. It gets in the way of being able to do some hobbies. And quite frequently it comes with a level of anxiety because you know you're going to have to get out of that scenario very quickly when the tremor starts. One common clinical presentation is called the hem sign. The tremor is so high frequency that you can see a person's fabric on their legs moving, almost like there's a breeze, a little bit of wind going past their legs. And that's how you can kind of notice the tremor without having to physically see it or feel it. So Becky, thanks for coming in today and having this discussion. Do you just want to walk us through a little bit of your history with orthostatic tremor and kind of how we started?
Well, I had been having symptoms and had gone to my internist and 3 or 4 neurologists and was sent for physical therapy for core strength and balance work and not diagnosed. And not long after you and I had worked together, I was using a cane when I had to stand still, and it was pretty frustrating not to know what was wrong with me. And thank you to you, you pushed me to follow up with another neurologist and even a second one after that, and came up with the diagnosis of primary orthostatic tremor, and we have been working on that ever since. And the difference that I feel in the work that you and I have done is pretty amazing.
Yeah, before we get into the specifics of that, maybe we can let everybody know kind of framing how you looked when we first started working together. So you had a wooden walking stick, a really cool one made out of a natural piece of wood. It had a little bow to it, and you would use that, but your primary limitation was usually, if I remember correctly, and correct me if my memory's not accurate, but within 1 to 2 minutes of standing, you would feel the need to lean against something. I can't remember if you were doing it or we had talked about it, but you would start to wrap your leg around the walking stick to gain some sort of proprioceptive input that would at least limit the intensity of the tremor, but it wouldn't eliminate it, I don't think. What do you remember about those early days?
The early days, I discovered that the tremor started when I was standing still, that I only had a very limited time before the tremor started, and I had to put my leg up against a solid chair or lean against the wall or put my hand on a table just something, and the tremor would actually dissipate. It didn't last very long, but when I was moving, if I was walking, running, just moving around, if I'm sitting down, if I'm laying down, there's no tremor.
Mm-hmm.
And I know when I first got to a neurologist who's a movement specialist through your encouragement and help, I discovered that it is such a high frequency tremor that you can actually hear it with the stethoscope by putting it on,
That's right.
on your leg.
Yeah, and that is referred to in the literature as the stethoscope test, so that it's a differentiator. Yeah, for sure. It's very interesting. So early on, Becky and I started to just kind of explore this condition together. I had some limited knowledge of what we would do, but her foundation of letting me know how it came on and how it presented, but also how it went away, helped us develop some strategies. What we discovered early on was the harder you try to resist the tremor, the worse it got, which was a key finding for us. So we went down the route of developing movement-based strategies that would be learned and largely gross early on, but then honed and refined into very subtle movements that were not distracting for community involvement. And we had to start with hip and knee movements, and then we eventually got onto what I refer to as piano keying of the toes and of the ankles, as well as some weight shifting. And I'll show you some clips of those as we kind of make this video for everybody that's watching. But tell us how those have really changed the scenario for you with orthostatic tremor.
It's made a huge difference. It has given me a longer period of time before the tremor starts, when I'm standing still or in a position like at an art gallery or standing in line for a concert or in the grocery store even. And it's increased the amount of time I can stand still. I'm really not standing still, but
Exactly.
Originally we were kind of doing some marching and moving my feet quite a bit, and that helped. And then we did more subtle things, even right within my shoes, and that helps probably even more. And so I use those, they're kind of automatic strategies now, because if I start them almost immediately when I'm forced to stand still for very long.
Right. So Becky and I figured out together that those were a key component. Now, this was a slow improvement over time, but as I mentioned, when I first saw her, it was somewhere between 1 and 2 minutes before the tremor became so intolerable that she had to modify her environment. And now with training sessions and social interaction, learning these strategies over time, we're up into the 25, 30-minute time frame before she needs to take a break. Now, remember, she's moving, but that can be subtle movements, or it can be an understood, hey, I need to take a few steps and move around and do something else. So that's a main portion, is the education of how to utilize these movement strategies to her benefit and adopt them into almost an unconscious strategy where you're just doing it to maintain your balance. Now, of course, Becky has reported to me that she has good and bad days. Some days it's worse than others. There's different components of lifestyle and anxiety and sleep and maybe even some medication that might make these worse or better. But we have been focusing on 3 major key points. I call them silos. So we've been focusing on the movement strategy silo. We've been focusing on the strengthening and cardiovascular fitness silos. So we'll talk about that a little bit. And then we also focus on the rehab silo, which the rehab silo is going to be more vestibular-based inputs and sensory processing of your environment. And so let's start with the the movement. Well, we already talked about the movement-based strategies a little bit, but let's talk about the cardiovascular one. You've been super motivated for several times a week, 2 or 3, at least, to go out and go for long walks, and you work with training dogs, which is a passion for you, which is great, and I think that actually probably helps the condition a little bit. But can you kind of walk everybody through that if you get those in, how you feel, or conversely, if you don't get that, that kind of light cardiovascular exercise in, how you feel?
Yeah, and I think I noticed that when you and I first started, and soon after I was diagnosed, that if I work out on the treadmill, even walking, and I think we started 10 minutes,
Mm-hmm.
and it wasn't a very fast walk on the treadmill, but we kept adding to that. And I felt like after 10 and now 20 minutes on the treadmill and the bicycle, I don't know if it is what it does to set up my whole system, but it makes the rest of our physical therapy session more successful for me.
Mm-hmm. It really acts like a warm-up for her. But you're also not just on the treadmill and on the bike, you're doing some other things. So tell everybody kind of some other things that you've learned have really helped kind of ground you and get you ready to do the rest of rehab.
Yeah, I also, when I'm on the treadmill and on the bicycle as well, I literally move sometimes just my eyes back and forth and refocus in as far as I can move. I do the same thing with my head while I'm working and running or walking fast on the treadmill or on the bike, and refocusing from distance to closer, focusing with my eyes. And that's helped a lot with just my general balance when I'm moving.
Yeah, so those strategies we referred to in rehab and therapy is, ocular motor reflexes. You have saccades, smooth pursuits, time zero viewing, where your head and your eyes are moving at the same pace with your neck, and then some convergence things. I think it's important that we had tried some of these strategies not on the treadmill and working on some rehab tools, but then Becky independently started doing them on the treadmill and in the community, and she said, these actually really help when I am able to not only just walk and be on the treadmill, but I'm able to integrate some reflexes through my eyes into my training. And so she adopted that independently, which was just a wonderful find. And we've been able to structure some things around that. But again, these things help her get primed to do the other things, and that includes strengthening. And so most of our sessions, not all, but most, include some aspect of carrying weights, lifting weights, doing step-ups onto level or soft surfaces, maybe some resistive band activities. We've tried to flip it up over time, but tell me what your thoughts are on our integration of strength and conditioning into your OT.
I think it's made a world of difference for me, and I feel stronger just to have the muscle strength to move when I need to. And also I think it helps with the work that I do, trying to stand still and use some of the strategies with just my feet or lower extremities while I'm standing. It's made a huge difference. I'm in better shape than I've been in for a long time, and I was pretty athletic as a young person, but this has kind of brought back some of that strength and I think energy level.
Yeah, well said. I think it's good for clinicians and patients who are dealing with OT to understand that it can be a downward spiraling cycle for these conditions as far as strength and conditioning and cardiovascular health. When you are limited with social interaction, when you're limited with the ability to stand, things will just get weaker and deconditioned over time, including your heart and lungs. That makes you more vulnerable to many things in the community, of course. And so Becky's been able to gain that aspect back in her life through some of our programs and specific conditionings. And that's why it's important to have conversations to make sure she understands, even if she's not in my clinic and getting treatment, she is understanding the purpose of these things. And I think she said it very well there, being able to know that she has the strength to adapt to her environment versus before, I don't think you did.
Yeah.
Yeah.
Before, I was avoiding a lot of social gatherings because it meant that I sometimes didn't have a place to lean against or stand next to or hold on to, and so I just avoided them.
Yeah.
And now I'm comfortable not only walking into a room and knowing where I can get some strength, but also being able to stand and use my strategies to talk to people up to 20, 30 minutes.
Yeah, which is amazing. Who needs to talk to somebody longer than that anyway?
Yeah,
right?
that's true.
And so then our final silo that we've worked on and integrated is more of a true rehab, which you already mentioned how we kind of adopted it into the cardiovascular realm. But we've used the motion guidance system very frequently so that you are working on better timing and control, put you on soft surfaces and had you do things with the laser to interact with the pods, had you carry weights and interact with the pods on the ground, all things that are just making your brain maybe be distracted in a way, but priming up all the systems that should be working for you during the day. How do you feel like that has improved your OT symptoms?
Not only has it felt like I had more control over the OT symptoms, it's given me the confidence to go back to being social and doing some of the things I love to do. And it's made a huge difference, truly.
Now you also will have some periodic symptoms that are not directly linked to OT. You'll have some dizziness at times, some disequilibrium, just some feelings of malaise and fatigue, which I think is going to also be just kind of a normal part of life for all of us. But I think you've also reported that going through training helps to start address those things, and of course we try to gear the sessions into how you're feeling on a given day. But I want everybody to understand that this is not just a linear progression for people. We still have other systems that are interacting, and who knows how you would feel if we wouldn't have done all this great work together. But we have to adapt our treatments into how the patient is feeling, not just do these simple things and you're going to feel 10 times better, 20 times better in your case.
Well, you ask me every time I come in how I'm feeling, what is different, is there anything different, and how I felt after the last session and what seemed to work and what didn't. And over time, it's very obvious to me which things really help. And some of them are a surprise. You started out, there was one point that you started out having me read a chart and standing and seeing how long I can stand and using some strategies. And somehow that changing your focus provided me more time before the tremor started. So I think together at least, I feel like we've come up with a lot of strategies that I can use, and each one works differently depending on the day.
Right. That's an interesting point too. How have we been tracking Becky's progress? So we've used a variety of questionnaires, but we've also had to find things that are relevant to your quality of life and say, well, how is that going? So initially, Becky's time to tremor was 6 to 10 seconds, if I remember correctly. So she would be able to stand for 1 to 2 minutes before having to sit down. But the time of just, I'm sitting, I don't have a tremor, I stand, how long does it take for me to feel my tremor, was very, very quick. Now that has definitely improved, and we're up into the 1, 2, or 3 minute mark now. But it's still important to understand that the time to tremor is still very quick onset, and that's where we need to use the movement strategies to keep that suppressed. This is not the condition that you're likely going to see, oh, now I can stand 20 minutes, I don't have tremor. That's not what's happening here. But the ability to adapt and have it be comfortable to at least stay in those environments. We've also used a patient-specific functional scale for Becky to track her progress over time. We've used a restless leg study group scale that we just adopted into orthostatic tremor. And then also her report on, so how long are you standing in the community with interaction before you have to sit? Now, we have had some hiatuses in care over our working together, sometimes several months based on some family issues that had to come up, and you had to travel and be out of your normal environment and support others. And Becky reported that during those times when she was less consistent, that she would have a regression of her symptoms, I think. And so these are going to be learned strategies that you will likely have to implement as part of a, well, this is just what I have to do to stay healthy. Much like eating well, much like doing exercise, cardiovascular fitness, you're going to have to kind of not get too far away from the program, I think, is our experience together. What do you say to that?
Absolutely. I noticed the change pretty quickly within a week, that the tremor's coming on faster, and I'm not able to use the strategies as successfully. But if I am consistent with the routine of physical therapy, I can maintain it easily. But I also notice when I get back on the schedule within the first 2 or 3 returns to physical therapy, I'm back where I started. Yeah. It isn't like I lose it forever, yeah. But I get back on track pretty quickly.
Yeah, there's definitely like a memory to it, it seems like.
There seems to be.
The system kind of likes the program. Now, one more component I'd like to talk about for the listening audience is medication. Obviously, there's a large influence within our healthcare system to try to give medication to help people immediately. It's all, I'm sure, well-intended, but oftentimes we're just giving, pharmaceuticals to say, well, let's try this. I've had patients with OT that have taken dopamine agonists. I've had patients that have gotten Botox injections. I've had patients that have taken oxycodone in the past, or Lyrica, gabapentin, types of medication. One thing that I've seen with most of my orthostatic tremor patients is that they have a very low tolerance to typical medication dosing. So if you were to take a 5 milligram dose of a standard medication that you might give to somebody, they can't tolerate that. It gives them very negative symptoms. So I have adopted the term microdosing for these patients. Pharmaceuticals could help this condition. In fact, I think you're still on a few, and I'll ask you about those in a moment. But really scaling back almost 80%, I think, is what we found of, or 75%. Having a pill and then having it again into quarters is almost what's necessary just to start to get a tolerance for this medication and not have side effects. So can you tell everybody the medications that you're on and maybe the recommended versus the actual dose that you're on, if you can remember?
Well, I'm using 1 tablet of primidone a day, and that's at night. And because I started that one after I started carbidopa levodopa, I am not sure what its
Right. Effect has been.
effects are, but the carbidopa levodopa seemed to be, and I had several other kinds of medications that I didn't tolerate. The carbidopa levodopa seems to be the most successful for me, and I take 2 tablets 3 times a day. I started out with 1 or 2 tablets a day. Now it's really 6 total. But it does seem to be the most successful for me.
Yeah, and much like other progressive degenerative conditions, there usually is an augmented necessity over time where you start as low as we can. In your case, we had to even start lower than a recommended dose because of failure to tolerance. And then we are improving that. If I compare that to the majority of Parkinson's disease patients that I'm seeing, there's usually an augmented phase that is happening on a monthly or annual basis, where it is very quick to go from a 3x3 to even more than that within a year, because the process of the symptoms can come back and return. So I think that Becky's slow progress of increasing her medication has been a very positive sign. It just took her a while to figure out even a brand made a difference of who was giving her the pharmaceutical, which be wary if you are getting switched to a same medication, you're not tolerating it well. I would start talking to your doctor about that.
Generics are not all the same.
Yes.
I have definitely discovered that.
And I think we have some published evidence suggestive that depending on where it comes in the world, you may or may not be getting the drug that you think you're getting. So if you notice changes in your body, definitely talk to your healthcare provider who subscribed that so they can see if we can make some changes.
Well, I think that's one of the advantages of coming in twice a week for physical therapy, because you ask me, and it's one of those things that makes me kind of evaluate how I really do feel and how I'm responding to medication. And over the 4 years that I've been coming to you, I think we're on top of it so quickly that I don't have the negative reactions to any of the medications. And if I do, we can talk to my neurologist and back off pretty quickly.
Yeah. Yes, communication is definitely going to be key there. And I think I pride myself in my practice of what Becky is talking about, which is making sure when patients come in, we have a good understanding of how their baseline feeling is during the day, what has changed from last time. Becky and I have been on care and off care for years, taking small breaks, seeing if we need refreshers, restarting with an addition of maybe a different symptom or condition. But it's always going to be the same. It's how are we feeling? How's it compared to last time? Let's redo some tests real quick, see how the body's reacting. Let's structure something. And most frequently, we usually go 3 weeks at a time of very similar programming if it's working well, and then we switch to other things so that we can upgrade you. So, well, thank you for coming in and talking to me about this. I think it's going to help the community have an understanding of maybe what orthostatic tremor, especially primary, is and what it looks like, how it might respond, maybe some of the motivational level that's required to get it done, and some of the specialty tools that can help, along with some different aspects of how we want to address this. So thanks for coming in.
I'm happy to be here. Yeah. Thank you.
All righty, buddy. Have a great rest of your day. And if you have any questions on orthostatic tremor, please reach out. Bye-bye.